It's 2025, a whole new year. In fact, it's January 10, 2025. Happy New Year to you. This is a Room Now podcast. I'm Jack Cush. Another year, another podcast. It's another good year in the neighborhood of rheumatology. This week, starting off the year, we've got reports on RA, vasculitis, gout, lupus, all the things that kind of sustain us. Let's get into it. I want to remind you, Room Now Live is coming up in about a month in Dallas. I hope you're going to be there. We'll talk more about that at the end. It is a great rheumatology meeting for great rheumatologists. Let's start with an interesting study about cardiovascular risk with osteoporosis therapies. This is a study of a high-risk population, 1,000 patients who are over the age of 50 and are on dialysis. They're at higher risk for fracture. They're at higher risk for a lot of things, including cardiovascular events. And I think that the question is, will they lower the fracture risk? Yes, they do. And will there be a cardiovascular risk? You know, these drugs in this arena have been plagued by the risk of major adverse cardiac events. It sort of starts with the use of calcium, bisphosphonates, not so much, but, hormone replacement therapy had a cardiovascular risk. Romosozumab has a cardiovascular risk. There's been a concern about it with parathyroid drugs. So in this particular study, 1,000 patients on dialysis over age 50, they either went on denosumab or an oral bisphosphonate for 3 years. And they were looking at what the benefits or harms might be. And they saw what you'd probably want to see, which is a significant lowering of risk. So denosumab was better than bisphosphonates at lowering the risk of subsequent fractures and lowered it by 45%. However, it did come with a 36% increase in major adverse cardiovascular events. Now, is there a risk with denosumab and cardiovascular events? Not previously been reported, but this is a high-risk population. And so maybe that's what we're seeing here. But I think that this is a topic that comes up quite often. I don't know if you agree with me, but I think hidradenitis is a disease that we rheumatologists should be treating. When you talk to patients with hidradenitis suppurativa, they often don't have a home. They're sometimes managed by surgeons, by primary cares. Should be managed by dermatology, but not all dermatologists want to manage this really complex medical condition that has a lot of comorbidity. So I report on this. We are going to have a great lecture on this on Sunday at Room Now Live. This is a phase 3 study of almost 600 patients who were treated with adalimumab. As you know, adalimumab is approved for the use in hidradenitis. So this is a post hoc analysis of one of those phase 3 studies, and they wanted to see what was the contribution of CRP. In their study, 79% of patients had an elevated CRP, high resolution CRP, and those who had high CRP levels did have more severe skin disease. They also tended to have more obesity and higher BMIs. And BMI and obesity is another risk factor for having an elevated CRP and acute phase reactant. So in this study, the high CRP patients had higher BMIs, 34 versus 28. They also had a lower odds of having an adalimumab response. So the question is, was it the inflammation that made them less likely to have an adalimumab response? Or was it the obesity, which we've talked about before, that contributes to being refractory to conventional therapies? So the lower odds, it was a 47% reduced risk of having an adalimumab response. So is this an activity story, or is this an inflammation, or is this an obesity story? I don't think you can disentangle them in a lot of patients, and I think you're just going to have to deal with it. So do you give higher doses? Do you stress weight reduction? Yes and yes. A Spanish study called the Arteser looked at giant cell arteritis outcomes over a 7-year period. They have 1,200 patients in this registry with more than 2 years of follow-up, and they looked at mortality rates. The 5-year mortality rate in their GCA patients was almost 40 deaths per 1,000 patient years, higher in males than in females, 59 versus 29 per 1,000 patient years. But the overall mortality rate was not that much higher, and it's not significant. It was a little bit higher, but not significantly higher than that's seen in the general population. And I think that's really kind of encouraging. Now, it's age matched. It's going to be elderly patients versus elderly patients. But I think that this is good news, and it says maybe something to how treating this highly inflammatory disorder might help avoid increased mortality. Those who were at higher risk for mortality were, as you might expect, the males and those who are older, because they're closer to death, are they not? That's what happens when you have a birthday every year. You get one step closer to meeting your maker. Aren't we starting the new year on a happy note? The protective factors in this study was having a headache, not necessarily having an ocular presentation, but having headache and hemoglobin were protective, meaning having higher hemoglobins had less mortality risk. Interesting. An EGPA study, retrospective review of 165 patients with EGPA and GI manifestations, shows that GI manifestations associated with eosinophilic polyangiitis was associated with high eosinophil counts, with an eosinophil percentage of almost 20% or greater than 19.5. Patients who had GI manifestations included those who had weight loss and also had abdominal pain, diarrhea, nausea and vomiting, GI hemorrhage, GI ulcers, rarely obstruction or pancreatitis. So the main manifestations were abdominal pain 80%, diarrhea 40%, nausea and vomiting in 33%. Patients who are at greater risk for these GI manifestations were those with weight loss and myalgia and high eosinophil counts. Don't see many EGPA patients, but I think that this is helpful, and I'll be looking for more in the way of GI manifestations. I like this report about RA care, and it's a study on nurse-led care, NLC, versus usual care versus rheumatologist-led care. This was a meta-analysis or literature review of 14 studies and almost 3,300 patients. And it showed that nurse-led care was highly effective, surpassed usual care, and was equal to rheumatologist-led care in both primary and secondary outcomes. And I think that this is maybe a lesson for us as we deal with manpower issues and patient overload issues, that you could have RA patients and protocolize their treatment and have it all being managed by your nurses. And they don't need to be advanced practice providers, although that's certainly another great option in dealing with the demands for care and the difficulty in finding and expanding your practice with rheumatology fellows. So nurse-led care working out very well. And by the way, this has been shown in other disorders as well, including gout, is one that quickly comes to mind. Another RA study looked at the German Biologics Registry in RA, also called the Rabbit Registry, that compared from their many RA patients. They compared looked at their RA-ILD patients, and they matched them with controls. And they found that high levels of sed rate and CRP were most predictive of an increased risk of incident ILD in RA patients. And surprisingly here is the sed rate and CRP that increases the risk, not DAS28, not tender joint count, not swollen joint count, not global assessment scores. It's inflammation that drives risk. So, we've talked about ILD. It's a big problem. There's a lot of research on it right now. We just covered ILD a lot at ACR and EULAR, and we saw reports that showed that when you treat RA aggressively, you can thwart the development of ILD. I think that this data ties into that well. Control of disease might help reduce the risk of RA-ILD, which, when that's present, is not good. Poorer outcomes, greater infection rates, higher mortality rates, more difficult to treat, and we don't have an approved therapy for RA-ILD. So using sed rates and CRPs as your biomarker makes a lot of sense in managing RA. An Italian study of almost 500 patients with RA found that 16% of them met the EULAR definition of difficult to treat RA, or D2T RA. This finding was unrelated to age, gender, seropositivity, but it was associated with 3 factors that are of interest to you. Patients who had difficult to treat RA were more likely to have erosive disease, meaning they're the real difficult patients. They're more likely, that's 24% versus 11%, double the risk. They are more likely to have obesity. We've talked about obesity being a factor, a cofactor in non-responsiveness, 33% versus 19%. And fibromyalgia, that's the subset of difficult to treat RA patients who are not going to respond to more aggressive therapy, whereas maybe those with inflammatory markers and erosions are the ones that would respond to more aggressive biologic or targeted therapies. But fibromyalgia doesn't. Again, the D2T-RAs, a quarter of them had fibromyalgia versus the non-difficult to treat, and that was only 10%. So again, I think that this is experience and observations that helps inform what we should be looking for in those who have difficult to treat RA. A real-world study of RA-ILD from Italy, the GISIA study, finds 165 patients with incident RA-ILD who are also treated with nintedanib. Now, I find this impressive because most rheumatologists I know in the United States aren't using much nintedanib. They're sort of waiting, referring to pulmonology, and waiting for someone else to start the patient on nintedanib. Now, maybe you are, but I don't see a lot of that where I practice or people I talk to. And I think this is an interesting experience here because it's 65 patients with RA-ILD on nintedanib. What's the outcomes? And it's not controlled. There's no placebo here. There's no other active control. It's just reporting the observation. Their 12-month retention rate on nintedanib was 77%. That's pretty good. And the drug was said to be effective in 80% of patients where they had stabilization of FVC. The problem here, of course, is side effects are common with nintedanib. GI side effects are problematic. A quarter of the patients here stopped the drug because of adverse events, mainly GI. Overall, the GI side effects were seen in 55% of patients. So I do think that we do need to be considering the use of either tocilizumab or nintedanib because the other drugs that we use, including rituximab, haven't really proven to be effective in these patients. But we need more research in this area. We need more trials like this. Speaking of ILD, a post hoc analysis of the DESIR study, a double-blind trial in scleroderma, looked at 48 patients who had systemic sclerosis-associated ILD and showed that rituximab did have an effect on lung outcomes at 24 weeks, but it was only going to be seen in patients with an elevated CRP. And the CRP elevation did not need to be very high. It just had to be abnormally high. And again, the difference between the rituximab and placebo groups was 8%, but that was felt to be significant in this trial. A study of lupus looked at fibromyalgia incidence. How many of your patients with lupus also have fibromyalgia? I got a number in my head that I would have said maybe a third, maybe 25%. This is a meta-analysis of 5,000 patients in many studies and showed that overall the frequency of fibromyalgia is 15.8%, almost 16%. But that lupus patients in these studies had a 3.7-fold higher risk of fibromyalgia, and that was significant by the odds ratios. So it's a confounder in management, in drug responsiveness, and also in assessing disease activity. So realizing that secondary fibromyalgia is a frequent comorbidity in SLE will make your life easier. Again, we have reports of the wonders of JAK inhibitors. This is a 5 randomized controlled trials looking at JAK inhibitors and whether or not they're effective in vitiligo, with the endpoint being repigmentation in vitiligo patients. So in this 5 trial, 1,500 review, it showed that greater than 50% improvement in total vitiligo score was 2.7 times more likely on a JAK inhibitor, or that 75% improvement in facial vitiligo was almost 4-fold higher when patients were treated with JAK inhibitors. So the JAK inhibitors had same amount of side effects as did the placebos, although there were more skin-associated AEs, and by that I would assume that they are meaning herpes zoster. So yet another example of where JAKs may work, and we're going to have a great discussion on JAK inhibitors at Room Now Live. We got a whole session, 4 lectures. John Giles talking about oral surveillance 3 years later. Maddie Feldman talking about what happens when JAK inhibitors go generic. Yes, it's going to happen. Christina Charles Schulman's going to talk about dermatomyositis and JAK inhibitors. And Joseph Marola, a rheum derm guy at UT Southwest, is going to talk about TYK2s and their effects. So I think you're going to enjoy that at Room Now Live. A report from Arthritis Care and Research looked at a 12-month study, randomized trial of 179 gout patients who started on allopurinol to lower the uric acid levels. Now, when that happens in the first 6 months, you get a lot of mobilization of uric acid and an increased rate of flares. So in the first 6 months, it's probably not a good idea to look at flare rates. But in this trial, the period from 6 months to 12 months, they found that flare rates went down significantly, that 38% of patients had no flares, 19% had 1 flare, and 43% had more than 1 flare. So still, flares are a problem in even patients who are on urate lowering therapy, with 43% having 2 or more flares between 6 and 12 months after starting allopurinol. The bottom line is that flares contribute to the impact of gout and ultimately gout outcomes. And it is something that we have to co-manage when we're using urate lowering therapy. Another report on gout looked at what happens when you lower uric acid levels in patients with CKD. Stage 3 CKD, and they found that if you lowered the uric acid to target levels of less than 6, you also lowered the future risk of severe kidney disease, worsening of their CKD, or even better, end-stage kidney disease, and that was significant. And my last report on gout looked at colchicine and whether it lowers the mortality risk overall. There's a number of studies out there that most studies showing that it does lower overall mortality, some showing that it does lower cardiovascular mortality risk and MI rates. And then you do know colchicine was approved last year for cardiovascular risk reduction. So in this very large database of almost 99,000, almost 100,000 patients initiating urate lowering therapy, 74% male, 85% white, the average age was 63 years. They showed that colchicine prophylaxis in these 100,000 gout patients was used in 16%. And in those that received colchicine, they had a significantly lower rate of cardiovascular events an 18% lower rate with a hazard ratio of 0.82. Those on colchicine had a rate of 29 per 1,000 patient years. Those without prophylaxis, 35 per 1,000 patient years. So it did lower gout flare rates, and then in this case, it did significantly lower cardiovascular event rates. So don't be afraid to use colchicine. We talked about GLP-1s. Somehow between ACR and the holidays, we missed this report from New England Journal about the use of GLP-1 receptor agonists in knee osteoarthritis. This is a 68-week trial of 407 patients who were enrolled to receive semaglutide weekly. The average age was 56, the BMI was 40, the WOMAC scores was 71 out of 100 for their knee OA pain. So there was a significant reduction in BMI of almost 14% on the semaglutide versus only 3% on placebo. That was highly significant. And those that were on the GLP-1 drugs, there was a significant reduction from 71 and a drop by 41 down to 30 out of 100, whereas there was only a 27 point drop in those that were on placebo, and that also was significant. So we've talked before about GLP-1s and their efficacy in gout, in RA, in lupus, and now also in knee osteoarthritis. You might have seen the report this week, sort of a nationwide assessment of electronic health records in over 10 million people in 6 large medical systems around the country, looking for the frequency of autoimmune disease, and they had a list of 105 autoimmune disease. They found that 5% of the population has an autoimmune disorder. This is actually less than what I reported last year, where I think it was as much as 10%, but a lot of this has to do with how you do it, right, with the methodology that's employed. Again, they did see, not surprisingly, that autoimmune disease was twice as likely in women compared to men, and that of those who had autoimmune disease, 2/3 had one autoimmune disease, 25% had 2, and 8% had 3. You know, the main ones were, as you might expect, RA, PSA, thyroiditis, I think were the top ones on the list. So if you're interested in that, you can find the citation on the website. Again, Room Now Live, February 8th and 9th, all day Saturday, half day Sunday. I think you want to be there. We've got a great session on JAK inhibitors, as I mentioned, with Madeline Feldman, Joseph Marola, Christina Charles Shulman, and John Giles. We're going to have a great panel discussion on this. We hope to see you in Dallas. Tune in next week. Happy New Year.